All right, so I'm just going to do a quick recap of what we talked about today in class. First is the fluid volume deficit. Causes of fluid volume deficit: increased hemorrhage, diabetes insipidus, burns, diuresis, and GI loss. Remember that you have a deficit, so anything that is going to make you lose fluid would be a risk factor. So signs and symptoms of fluid volume deficit: you don't have any circulating fluid, you don't have any volume, so your blood pressure is going to go down. To compensate for your blood pressure going down, your heart rate's going to go up. What's it going to feel like? Its characteristics of it. It's going to be weak and thready because there's no circulating volume. You're not going to have good skin turgor. You're going to have dry mucous membranes. You're going to be holding on to any urine that you have, so you're going to have oliguria. Your labs, you're going to have increased hematocrit, increased BUN, increased sodium. Level of consciousness is going to go down. How do you manage this? Well, if they can do PO, you're going to give them PO. If they can't, you're going to give them intravenous fluids. The doctor might want to do a fluid challenge test to see if the kidneys are causing an issue, if they're not functioning. And the way that would work is you would bolus them 500 mLs and they should pee it out. And if they don't, there's probably something wrong with the kidneys. You're going to monitor their intake and output, do labs. You're going to assess. What are you assessing? You're going to assess lungs, heart, tissue perfusion, muscle strength. Going to do skin care, breakdown. Skin breakdown happens when you have fluid volume deficit. Level of consciousness. So that's fluid volume deficit in a nutshell. Fluid volume excess is when your extracellular fluid is expanding because you have too much water and sodium. You're overloaded. What are some risk factors? Well, heart failure, cirrhosis of the liver, renal failure, anything that would make you hold on to fluid is a risk factor. So some signs and symptoms. Well, you have too much fluid, so your blood pressure is going to go up. And again, you have all this circulating fluid, so your heart rate's going to go up. But this time it's going to be bounding. You're going to have LOC changes, headache, crackles, because you might have pulmonary congestion because your fluid has gotten backed up into your lungs. You're going to have increased jugular venous distension, pitting edema. Labs, you're going to have low hematocrit, low BUN, low sodium. So how do you manage hypervolemia? Well, you're going to do some diuretics. If it's a mild hypervolemia without sodium issue, you're going to use thiazide diuretics. If it's a moderate to severe hypervolemia, you're going to use a loop diuretic such as furosemide. Diet, daily weights, eyes and nose. You're going to monitor. You're going to identify those at risk. You're going to assess heart sounds, breath sounds, level of consciousness. Look at their labs. If they need dialysis, if it's severe, they'll need dialysis. So some labs, electrolyte disorders from your certain electrolytes, sodium is one of them. You have two forms of hyponatremia. One is true, one's delusional. So true hyponatremia results from vomiting, suctioning, diarrhea, being NPO, not taking in enough salt. Basically, you are having a fluid volume deficit and you don't have sodium to go with it. The signs and symptoms: if you don't have fluid, you have a deficit, then you're going to have orthostatic hypotension because you don't have any fluid going around. You're going to have an increased heart rate. You're going to have LOC changes. You might have some nausea, vomiting, and diarrhea because those are risk factors. Weakness. So how do we treat it? Increased oral intake. Isotonic fluids. Very rarely, and if it's a really low hyponatremia, they might do hypertonic solutions. These are done only in an ICU setting. I've been a nurse for 12 years, and I have given a hypertonic solution like once. So it's not something that you're going to do regularly. Eyes and nose, seizure precautions for anything sodium related, seizure precautions. Daily weights. Dilutional hyponatremia is when you have basically a fluid volume excess, but you don't have enough sodium. So excess water gain by inappropriate administration of IV fluids is a risk factor. Heart failure, renal failure, cirrhosis, water intoxication, which is basically a mental health issue. You have a sodium level less than 136, and with this fluid overload but not having enough sodium, you're going to have weight gain, edema, confusion. Ways to manage it. Again, you want to identify patients that are at risk. So who's at risk for this? Well, your heart failure, renal failure patients, your cirrhosis patients. You're going to assess for signs and symptoms of hyponatremia, so confusion, weight gain, edema. You're going to restrict fluid intake if it's dilutional. Monitor your eyes and nose. Place on dietary measures. Educate the family on treatment, prevention, signs and symptoms to look out for if they come in with hyponatremia, what they need to know when they go out with hyponatremia. So hypernatremia is risk factor is excess sodium intake. How about that? You can give somebody hypertonic tube feedings and not give them water, and that is also a risk factor. Hyperaldosteronism, renal failure, and Cushing's. It's greater than 145. So when you think about hypernatremia, think about how you feel after you eat some salt. So you feel thirsty and your mucous membranes are dry. You have increased heart rate if your hypernatremia is been going on a little while. You could have a low-grade fever, flushed skin. An acronym to remember with hypernatremia is called fried salt. And fried salt stands for flushed skin, restless, increased blood pressure, edema, decreased urine, skin flushed, agitation, low-grade fever, and thirst. Look what it does to your osmolality. It's going to make it high, and it's also going to make your specific gravity in your urine high. So, management. Well, we identify those at risk. We assess signs and symptoms of somebody that's hypernatremic. We want to look for those. We want to monitor our eyes and nose. If we have a patient that's getting a tube feeding, we want to collaborate with our nutritionist to make sure that we can give free water to flush our tube feeding with so they don't get hypernatremic. If they can take PO, encourage them to take fluids, but to decrease their sodium. So maybe no broth, no sodas. Put them on seizure precautions. You have somebody that has a sodium issue, seizure precautions are a good thing. And then, of course, you're going to educate. Then we have potassium issues. So hypokalemia is less than 3.5. GI loss is a big causative factor. So vomiting, diarrhea, renal losses, certain meds like loop diuretics and insulin, corticosteroids, if they don't have good nutritional status, or their TPN, total parenteral nutrition. So they can have fatigue, muscle weakness, paresthesia. Important thing to remember about potassium is it affects muscles. So it's not just that your heart is affected, it's that your muscles are affected, which is why you have the muscle weakness. You could have shallow respirations because, hey, a big muscle to help us breathe is called the diaphragm. And then EKG changes, U wave, cardiac arrest. Hypokalemia can also potentiate ditch toxicity. A good acronym to remember for hypokalemia is a sick Walt. Walt is very sick. Alkalosis, right, because alkalosis, hypokalemia, K is low. Shallow respirations, irritability, confusion, weakness, arrhythmias, lethargy, and a thready pulse. So how do we manage this? Well, we are going to identify the patients that are at risk, and we want to assess for signs and symptoms of this. We're going to administer a potassium replacement, so if they can take PO, if it's not terrible, give them PO. If it's low, give them IV. Never give potassium IV push. Potassium IV push is known as lethal injection. You also don't want to give potassium IM. You don't want to give potassium sub-Q. You don't want to crush potassium. Potassium hurts. It's kind of irritating to the veins. So if they complain about it hurting, first assess your IV and make sure it's not infiltrated. And then after you determine that your IV is not infiltrated, you want to dilute. Never want to give IV potassium faster than 20 milliequivalents per hour. You want to monitor for complications of therapy and of hypokalemia, and you're going to encourage intake of high potassium foods such as fish, orange juice, fruit. Place them on a cardiac monitor if their potassium is low, like 2.8 or low. And again, educate. Hyperkalemia is caused by kidney insufficiency. Certain meds such as potassium-sparing diuretics, ACE inhibitors, Addison's disease can cause it. So if they have a level above 5, it's considered hyperkalemia. A big cardiac issue with hyperkalemia is your EKG is going to have tall, tinted T waves. It's a hallmark sign right there. You can have muscle weakness, nausea, vomiting, diarrhea. An acronym to remember with hyperkalemia is the acronym MURDER, which stands for muscle cramps, urine abnormalities, respiratory distress, decreased cardiac contractility, EKG changes, and reflexes. Your reflexes are decreased with hyperkalemia. Management. You want to identify those at risk. Assess the diet to make sure that they aren't excessively using salt substitutes, because that's what they use for a salt substitute is potassium. Assess for symptoms of hyperkalemia. Have emergency equipment available. Assess for acidosis, like DKA. Calcium gluconate, IV for emergent. It helps to decrease the myocardial irritability. And then you also want to administer regular IV insulin and glucose. IV insulin, one of its functions is to help move potassium back into the cell. You give glucose so they don't bottom out on you. And then if it's also emergent, you are going to prepare them for dialysis. If it's not emergent, they might just use some Kexlate, but the use of Kexlate is decreasing. And then, of course, again, you want to educate. So, calcium, 9.0 to 10.5. Some causes of hypocalcemia: renal failure, acute pancreatitis, vitamin D deficiency, hypoparathyroidism. You have a level less than 9.0 to be hypo. You're going to have stridor, positive Chvostek's or Trousseau sign. Chvostek's is facial tapping. Trousseau is like arm twitching with the muscles when you raise the blood pressure. Your clotting times are going to be elevated because you need calcium in your body to help clot. And so if you don't have calcium in your body to help clot, then your clotting is going to take longer. Tingling and numbness. Tetany, a good acronym to remember for hypocalcemia, is CATS. So CATS stands for convulsions, arrhythmias, tetany, and stridor and spasms. So treatment. Again, we want to identify the patients at risk for hypocalcemia, assess for symptoms of hypocalcemia, encourage weight-bearing exercises. Calcium needs to get out of our bone and into our blood, and the way we do this is with weight-bearing exercises. You could do oral replacement and then IV replacement, calcium gluconate, and education. Seizure precautions, and if the calcium is low, then you want to put them on a cardiac monitor. So hypercalcemia is a risk factor: excess intake, Addison's, hyperparathyroidism, and immobility, metastatic bone cancer. So if it's greater than 10.5, it's considered hyper. Your signs and symptoms: muscle weakness, muscle aches, some cardiac issues, nausea, vomiting, anorexia, constipation, confusion. So how do you manage this? Well, you identify the patients at risk. You encourage ambulation. You restrict calcium. Maybe give them a loop diuretic to help with calcium excretion. You want to move the patient carefully to help prevent fracture. You want to encourage high acidity juices that helps dilute and absorb the calcium. And again, education. And then magnesium. So that's not the right level. ATI says 1.3 to 2.1, so don't get all upset about the level on the piece of paper there. Causes for this are GI loss, nausea, vomiting, excessive suctioning, Crohn's disease, burns, certain meds, acute pancreatitis, DKA, biggie, alcoholism. So if your level is lower than 1.3, you could have EKG changes, cardiac dysrhythmias, an increase in your DTRs and seizures, a positive Chvostek and Trousseau. The way to manage is to identify those at risk and assess for signs and symptoms, to provide oral replacement or IV replacement if it's bad enough. And then if you need to implement safety and seizure precautions, you should. And then hypermagnesemia is caused by acute and chronic renal failure. And there's some meds that cause it, anticholinergics and narcotics. So your mag level will be above 2.1. And again, some cardiac dysrhythmias. With this one, you'll have decreased heart rate and complete heart block. You want to identify those at risk and assess for signs and symptoms. So one sign and symptom is decreased absent DTRs, deep tendon reflexes. So if you're assessing and your patient does not have deep tendon reflexes, then you need to let the doctor know. You might do some loop diuretics if level is high enough, some IV calcium gluconate, and again, education. So then we talked about fluid tonicity. So we have isotonic, hypotonic, and hypertonic. So isotonic fluid is basically the same ECF, ICF. It's the same serum osmolality. So there's no real exchanging between the two. some examples of isotonic solution: normal saline, lactated ringers. D5W is isotonic outside the body, but once it gets inside the body, it's hypotonic. So normal saline just has electrolytes in it, and then lactated ringers is going to have electrolytes and lactate. So your hypotonic fluids right here, you're going to basically make your cell swell. That's this one right here. So a way to remember that the hypotonic fluid actually makes your cell get bigger is you want to maybe think hippo, because hippos are large. And so hypo and hippo means your cell is swelling. Some patients that you would not want to use a hypotonic fluid on are patients who have an increased intracranial pressure or at risk for an increased intracranial pressure, and then patients who are at risk for third spacing. So increased intracranial pressure symptoms, level of consciousness changes, motor sensory deficits, and pupillary changes. And then those at risk for third spacing are people with liver disease, burns, and trauma victims. Your osmolality is less than 275 with hypotonic. And if normal saline is isotonic, it's 0.9%. Anything that is less than 9% is hypotonic. So half normal saline, a third normal saline. D2.5W is also hypotonic. And then hypertonic is the fluid going out of the cell and into the extracellular phase. So your cell is shrinking. So a way to remember that is that if you're hyperactive and running around everywhere, you're skinny. So your cell gets skinny because it's getting hyper. So patients at risk for cellular dehydration should not receive these kinds of fluids. And like I said earlier, hypertonic fluids are only administered in an ICU setting. Their osmolarity is greater than 295. Some examples, so if normal saline is 0.9%, so anything above 0.9% is hypertonic. So a whole number, like 3% sodium chloride, is a hypertonic solution. D10W is a hypertonic solution. So some delivery methods with your IV, you have peripheral, you have extended length catheters, and you have PICC lines or central lines. Peripheral, everybody can put in. Extended length catheter is something that the IV team puts in. It's good for 30 days. And then you have central lines, and your PICC is a central line. So some reasons to have a central line: you have a patient that is on a total parenteral nutrition, they require a large volume of fluid, they need medicines that could cause vessel irritation, such as vasopressors or a lot of IV potassium. Anything that can cause vessel irritation is a vesicant, and usually they need a central line. Frequent blood draws, long-term antibiotic therapy, those are your big reasons to having a central line or a PICC line. They try not to leave a central line in too terribly long, but a PICC line can stay in for quite a while. Not sure exactly how long, but it can stay in for months. So some complications that you need to know about of IV therapy. Infiltration is a complication. What infiltration is fluid leaking into the vein. So the way to prevent infiltration is to always get the smallest catheter needed. You do not always need an 18 or a 16 gauge catheter. If you are in a trauma setting and your patient is, dying, then yeah, you probably need a large catheter. But for the majority of things of what you will be doing, your patient does not need a large catheter. They can survive with a 20-22. You want to secure it in place, and you want to avoid joints because joints are bend and you have infiltration quicker. So some signs and symptoms of infiltration: swelling at the site, pooling, blanching of the skin. Then we have phlebitis, and what phlebitis is inflammation of the vein. Anything that ends in itis is inflammation. Some signs and symptoms of phlebitis: pain, redness, swelling, sluggish flow. If it gets bad, they could have a fever. So ways to prevent phlebitis. Well, you want to use a large vein and rotate sites per policy. Then we have extravasation. And extravasation is like infiltration, but it's medicine that's considered a vesicant that has leaked out into the surrounding tissue and has caused extravasation. So it becomes necrotic, basically. I showed pictures in class of what extravasation looks like. You can have burning, pain, blistering, necrosis, and you want to treat per policy. The very first thing you're going to do is stop the infusion. You want to notify the doctor. You want to remove, and you're going to do ice soaks, warm soaks, and antidote, depending on what your policy says. You're going to assess function of the limb, nerve function, and circulation. Then there is air embolism, which is very, very, very rare these days. I have never seen one, knock on some wood. So what you do if you have somebody that has an air embolus is you're going to place them on the left side and lower their head and tell the doctor. The signs and symptoms are blood pressure decrease, heart rate increase, respiratory distress, ICP increase, and loss of consciousness. So to avoid this, you want to prime all your tubing, tighten your connections, and use an air detection device. So nursing care of the patient with an IV. Check the IV order for completeness and accuracy. Eyes and O's, daily weights. Always, always use sterile technique, and always, 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 always use a regulation device, preferably a pump. That is the most accurate. If you, again, are in a trauma setting and you have to get fluid in them, have to get blood in them like quickly, then a pump takes a little while to get and you might not be able to use it right away. But anytime you are able to, you always use a pump. Always, always, always. And remember, always want to focus on the patient. Always listen. Always educate. So if you have a patient who came up from the emergency room and their vein, their IV is in the antecubital, the bend of the arm, and they're alert and oriented, and they keep wanting to bend their arm and it's making their pump go off, you need to let them know, don't do that. And you want to tell them why. You want to tell them, if your IV starts hurting, let me know. So teach and listen to your patient. All right, I hope this has been fruitful. If you have any questions, let me know.